From Penn State Health, Milton S. Hershey Medical Center, welcome to Ask Us Anything About Breast Cancer. I'm Scott Gilbert. This is the latest in a series of conversations we're billing as Ask Us Anything About, and you'll find them here on our Facebook page, and it's a chance for you to learn about a range of medical topics. Did you know that 1 in 8 women in the U.S. will develop invasive breast cancer? As October is Breast Cancer Awareness Month, we want to take the opportunity to address some important questions. Some of those include, how can you understand your risk? What screening options are available? And when cancer is detected, what factors determine the course of treatment? Here to help us answer those questions today is Dr. Dalila Dodge. She's a breast surgeon at Penn State Breast Center. Thank you for being here, Dr. Dodge.
Thank you. I'm glad to be here.
Well, let's start by talking about screening, because I know the American Cancer Society sparked some debate last year by suggesting that most women can wait until age 45 to have their first mammogram. Another organization says it's 40. Another one says 50. How should women navigate those waters and try to figure out when it's right for them to get their first mammogram?
So the first thing we want you to be aware of is that those screening recommendations are for the woman with an average risk of breast cancer. There are two groups of women that stand out as being at higher risk of developing breast cancer. Those women who have a family history of breast cancer, especially when the breast cancer has occurred in the premenopausal years, and also those women who have mammographically dense breasts, which until you get your first mammogram, you don't know if you have mammographically dense breasts or not. The screening guidelines that have been developed are as a result of a preventive task force meeting that saw a lot of downsides to screening mammography that included a lot of callbacks and what we call false positives, where you do a biopsy and the biopsy turns out to be benign. And a woman has to balance that against her own concerns about developing breast cancer. We also know that of the women who have breast cancer diagnosed under the age of 50, about 60 to 80% of them do not have a strong family history of breast cancer. So just because you don't have a strong family history of breast cancer does not mean you won't develop breast cancer at a younger age. It has to be a conversation with your doctor, and we also recommend that you consider having one or two of the risk models, such as the Gale model, the NCI, or the BRCA Pro model, performed to look at your own risk. Again, if there's any family history of carrying the BRCA gene mutation or other genetic mutations associated with breast cancer, you're not talking about those women. Those women start at a much earlier age.
But as you said, though, a very large percentage of breast cancers caught before the age of 50 involve women with no family history.
That is absolutely correct.
Okay. Well, there are some excuses we hear sometimes. Women will say, I'm afraid that mammogram is going to be too painful, or I simply don't have the time. Do you hear those excuses a lot as a practitioner?
Absolutely. We all have very busy lives, and in our busy lives, we all are looking for some way to make them less busy. But screening mammography definitely saves lives, and the vast majority of women that I see today in my office do not feel anything or find any symptoms. So screening mammography is the key to early diagnosis.
When we talk about family history, are we talking about immediate family, such as somebody's mother, or can it go even broader than that? Are there other family members who we should keep an eye on?
Well, any family history of a male member with breast cancer is a big red flag for carrying a gene mutation and having a higher risk, and that's any male member. A history of ovarian cancer in your family also increases your risk of carrying one of the gene mutations and increasing your risk of breast cancer. And while first-degree relatives, those like mother and sister, carry more risk for you, second-degree relatives, your aunts, your cousins, also will add to your risk.
You're watching Ask Us Anything About Breast Cancer from Penn State Health, Milton S. Hershey Medical Center. I'm Scott Gilbert alongside Dr. Dalila Dodge. She's a breast surgeon at Penn State Breast Center. We welcome your questions, whether you're watching this as a live feed on Facebook here on Monday at noon, or even if you're watching after the fact. Feel free to post your questions to the comment field of this Facebook post, and we will track down an answer for you and make sure we post it as a reply. Now, we've been talking a lot about mammography, but there are other types of screenings that, depending on a woman's risk factors and some other items, may be appropriate. We're talking about things like 3D mammography, whole breast ultrasound. When do those screening techniques come into play?
So 3D mammography is similar in its place now to what digital mammography was 10 years ago to analog mammography. It's an improvement. I think it's an improvement that is going to eventually be present in all screening and diagnostic settings. Now at Hershey, we're using it in the screening setting, and there are many other centers in the state who are currently using tomo or 3D mammography for their screenings. The reason for that is that the callback rate is about 30% lower, so less women being called back for what turns out to be nothing, and about a 6% better pickup rate for breast cancers. Automated breast ultrasound is being used in some centers, and we have it available here for women who have very dense breasts, because we know that in the women with dense breast tissue, we can miss cancers.
How would a woman know if she falls into that category of having dense breast tissue?
We will actually tell the woman after her mammogram whether she has dense breasts, extremely dense breasts, if that is so. Unfortunately, about 50% of women are going to fall into one of those two categories.
I have a friend who has beaten breast cancer twice, and at the beginning of every month on her Facebook page, she posts a notice to remind her friends, it's time to do your self-exam, ladies. She does it every single month. How important is that self-exam, and how often do important findings surface from that?
Well, one of the interesting things is that breast self-examination, that was one of the keystones of diagnosis, is no longer considered something that we should be doing. We're supposed to be breast aware. Breast aware means know your breasts, know what they feel like, and report any changes to your doctors. But the concern was that women were feeling all kinds of things that turned out to be nothing. Same thing as our concerns about screening mammography. It is very important, however, that we do examine our breasts and that we do it on a routine basis. And I like the concept of doing it at the beginning of the month. It's an easy way to remember to do that.
So being aware, being self-aware is very important.
Any thickness, lump, discharge that's spontaneous, or any other change in her breast, such an area of redness that just doesn't go away or doesn't respond to antibiotics. Those are warning signs of cancer. Dimpling on the breast, changes in the contour of the breast.
Just a reminder to post your questions for Dr. Dodge in the comment field below this Facebook post, and we'll pass those along to her here and ask her to answer those in this edition of Ask Us Anything About Breast Cancer. Demographically speaking, what groups of women are at the greatest risk of developing breast cancer?
Well, all women are at risk. The women that are at least risk are actually those of Asian descent. In the premenopausal years, black women are at much higher risk of developing breast cancer than are Caucasian women. But in the postmenopausal years, it flips, and Caucasian women are more at risk than are those who are black. So it changes depending on your age, but we all have a significant risk of developing breast cancer.
Now, with all types of cancer, we hear that everyone's cancer is different. Each tumor is different. So if one woman has a tumor in the left breast, another woman has a tumor in the left breast of the same size, it could be two very different types of cancer, right?
There are 4 major types of breast cancer in terms of their markers and their aggressiveness. And we can't really talk in detail about those, but it's important to know that there are breast cancers that grow very slowly and that recur more rarely. And then there are breast cancers such as triple-negative breast cancers that grow very quickly and are extremely aggressive and are responsible for a large proportion of the deaths from breast cancer. And just because you've had one type of breast cancer doesn't mean you can't develop the other type of breast cancer as well.
So let's talk a little bit about treatment options and what determines a course of treatment. There are a wide range of treatment options, obviously. There can be chemotherapy, there can be radiation, and of course surgery as well. What determines, and I know this is a very broad topic to get into with just a few minutes left, but what are some of the factors that determine that course of treatment?
Well, we actually are a multidisciplinary team here, as are all good breast centers, and we meet and we discuss every patient's case so that we can optimize the way they're treated. Pretty much everything starts in radiology with imaging, and then most women will see a surgeon next. But surgery as the first treatment for breast cancer isn't always the right choice. Sometimes we'll give systemic treatment, chemotherapy or anti-hormonal therapy, before we have surgery for various reasons. And radiation is part of the treatment paradigm, certainly when we conserve the breast, and sometimes even if we require a mastectomy. So it's a complex treatment tree that we go through. Most importantly, it needs to be done with all the experts together and on working on the same page.
As we begin to wrap things up, I want to go back to that first concept. I think the key takeaway here is going to have to do with screening and when women should get that first mammogram and how often they should. But really, it sounds like your advice is it all begins with a conversation with your physician, correct?
And that should occur at your 40th birthday or even earlier, especially if there's a family history of early premenopausal breast cancer, in which case you should really be talking to your physician before the age of 40. But a nice way to celebrate your 40th birthday is to have that conversation with your physician, have any kind of risk model done, and then make a decision as to where mammography screening fits into your life. I'm hoping that most of you will choose to have early screening because it does save lives.
We have additional information for you online from Dr. Dodge. In fact, last week's Penn State Medical Minute is dedicated to holistic health and breast cancer and integrative medicine and how all that interplays. So some very interesting stuff we didn't have time to touch on today, but I hope you'll go and check that out at PennStateHealthNews.org. Also, this Thursday, we will have a call-in show and also a web chat from WHTM TV, ABC 27. Some of the experts from Penn State Breast Center will be involved with both the web chat and the call-in show. You can find details elsewhere right here on our Facebook page for Penn State Health Milton S. Hershey Medical Center. You can also find out more information about the Breast Center at PennStateHershey.org/breast. The phone number to call is our care line, 800-243-1455. Dr. Dodge, thank you for your time today. I appreciate it.
Thank you, Scott. It was great.
And thank you for watching Ask Us Anything About Breast Cancer. I'm Scott Gilbert.